in Montefiore in New York, Professor Nogah HAMARATI, who came especially for us and for the election.
Hi, thank you very much. Thank you, Laurence, for this invitation. This is very unusual for many reasons. One, it's the first meeting that I've ever had coming to Israel to vote, and also having a musculoskeletal course. Second, even more important, this course is known among insiders as Laurence's women's course, because most of the lecturers are women. And so I actually thought I should come in a dress and heels. And then I thought that maybe they wouldn't let me vote, because my voting place is not Tel Aviv. So, but I'm very happy to be here. And what I did was I put together 7 cases in a Laurence style. For those who, I just met Laurence in September, and for those of you who know Laurence is as informal as French a radiologist as you will find, and interested only in what's the facts, what can we learn, what can we do better, and that's it. And so, I'm showing you 7 cases, and the format is open. This is not I lecture, you sleep. This is I show, and then you call out thoughts and ideas. The purpose of this is so that you walk out of here and say, I learned something. Okay, the histories, the cases are all set up according to the United States American Board of Radiology format. And so you'll see extensive histories like this. Okay, so you can start. Anybody have any thoughts, what you see on the plain film? Okay, there's obviously some edema at the lateral surface of the thigh, and there's quite a bit of soft tissue swelling. Okay, here we have the CT. Any thoughts? So we see the muscle, and the character of the muscle appears normal. We see the subcutaneous tissues, which is standard ordinary blubber. And then between the subcutaneous tissues and the muscle, we have this collection. Any thoughts? Excuse me? Morel-Lavallée syndrome from a French speaker. That sounds absolutely correct. Here is the MRI. And you can see the Morel-Lavallée syndrome, a closed degloving injury syndrome, and we can see the hemorrhage all along the interface between the muscle and the subcutaneous tissues. These are the post-gadolinium images that show enhancement just at the rim. And correct, Morel-Lavallée syndrome, outstanding. Next case, 29 female. Okay, so, yes? Lisfranc, right. So it's a Lisfranc. So the question is, why? Why does this 29-year-old active woman have a Lisfranc? Okay, so on the radiographs, the answer does not seem to be apparent. So here's a CT. Any thoughts? Right, Lisfranc is very common, but we usually don't see it in active 29-year-olds. Any thoughts? Okay, so we see the Lisfranc very clearly. It's actually very nice, this dorsal fracture dislocation at the second metatarsal. But what's going on? This is the navicular and the cuboid. And what's going on at the navicular cuboid articulation? There's joint space narrowing, and there's irregularity at the joint space. So what would that be? Tarsal coalition, correct. So tarsal coalition at any point in the foot causes loss of the normal flexibility of the foot, and that sets the individual up for a secondary injury. In musculoskeletal world, injuries beget injuries. Somebody who has one injury is more likely to get a second. So over here, this person has lack of flexibility in the foot, so this is an interference with the whole longitudinal arch function. And in this situation, you can't simply look and say, oh, it's a classic neuropathic disease. It's not necessarily neuropathic disease. It's loss of function, loss of flexibility of the foot. And if the person continues to try other areas of the foot, they'll try to take over the flexibility functions, and then they can sustain serious injury. And here you see on the axial, here's the Tarsal Coalition again. It's very easy to be, I mean, everybody can see the Lisfranc dislocation, but it's always what is the underlying injury? The problem is, if you find it now, it doesn't help the patient because you can't fix this. The trick would have been to find this before the person was injured. And of course, this is the injury, this is the repair of the Lisfranc, but at this point, taking care of the Tarsal Coalition is pretty moot. Although at age 29, it's already questionable what you can do. Next case, 29-year-old female. So? It's not the same female. Okay, so the question is, what's all this hazy stuff? What is all of this? Okay, so here's the question. Sometimes you look at something and you say, oh, I've seen this before. But then you look and say, oh yeah, I didn't know what it was last time either, so I don't know what it is now. And that might be the case. So just out of curiosity, how many of you over here, by show of hands, look and say, oh yeah, I didn't know what this was last time I saw it? Anybody? 1, 2. Okay. On the frontal, you really don't see anything. So now it turns out, this is a different patient who has the same thing. What is this? Implants, right. So the implant is actually silicone. So these are silicone implants in the butt for a person to have a shapely butt. And these are free silicone injections. These are not implants. Neither of which I would recommend. Exercise and eating less cakes and stuff is probably the recommended approach. Okay, so these are butt silicone injections. Good. Now a 77-year-old male. Now I'll tell you, when I met Laurence in September, I met her at the International Skeletal Society, and the International Skeletal Society has one part of the society that's very focused on tumors. But whenever tumors came up, I noticed that Laurence's breathing slowed down, and I was afraid she would go into cardiac arrest. And so I did not bring any tumors, because we didn't want to cause any issues. So we're not dealing with a tumor. That's a good hint. But what's going on here with this shoulder? What is this? Here we see the acromion, and beneath the acromion we can see the subacromial space, and there's stuff here. So we could see on the stir that there's definitely something filling the subacromial space. We look on the T1. On the T1 it looks fairly homogeneous. T2 fat suppression, it looks like there's something in here, and proton density fat suppression too. What could possibly be doing this? 77-year-old male. A what? Arthritis. Yeah, arthritis can definitely do. Oh, rice bodies. Yes, absolutely. These are rice bodies. That's exactly what they are. Now, question is, the differential of rice bodies, it ranges from arthritides, such as rheumatoid arthritis, down through infectious synovitis, such as tuberculosis and other disorders. So, the real question is what this is. And when we looked at this, we said, yeah, these are rice bodies, and we had the same question. What is this? Here's the CT, and you can see the CT doesn't show any erosions. It's pretty unremarkable. It just shows some distension, and that's it, in joint space narrowing. This turned out to be Acinetobacter baumannii, which you look and say, who cares? Turns out this is a really important bacterium. It's an aerobic, gram-negative, multi-drug resistant, opportunistic bacterium that has a very high fatality level. In the United States, there is currently a fear by the CDC that this can rise to be a bigger threat to public health than MRSA. Now, in the United States, it has a name. It's called Iraqibacter. For those who take care of Iraqi soldiers, these are young, healthy soldiers returning from Iraq who were wounded in Iraq. There's been quite a number of them who came infected with this with a high mortality rate. So that's how we got the name Iraqibacter. So this name, if you've never heard it before, Acinetobacter baumannii, it's a name that you should probably keep in mind. And if you see something where you look and say, yeah, it could be nothing, well, it could be something, because if it is this, then you can't just treat it and say, well, it just might be early rheumatoid or something. Okay, 36-year-old female. Any thoughts? We look at the stir, coronal stir, and we see there's increased signal here at the subscapularis. But we look at the T1, and there isn't any atrophy, which means whatever we're dealing with is very acute. We look at the T2 fat suppression, and we can see that the increased signal is really only part of the muscle. We're not seeing involvement of the entire muscle on the T2 fat sac. And on a T2 star gradient echo, same thing. It's only a part of the muscle, but it's diffuse. There's no mass effect here. So, and there really isn't any hemorrhage. It's not like this is an avulsion of the infraspinatus that you could see as an acute avulsion. Because those are accompanied by a lot of hemorrhage, and you see evidence of an avulsion. This is not an avulsion. Something's causing the muscle itself to become edematous in an acute manner. What could do this? Innervation. Absolutely. This is acute subscapularis brachial neuritis. This is called the Parsonage-Turner syndrome. Now, Parsonage-Turner syndrome itself is rare. And when you see the Parsonage-Turner syndrome, you can usually identify it because there are multiple muscle groups that are affected. Identifying the Parsonage-Turner syndrome, when you have an isolated branch, like the subscapularis branch itself, that's affected, is more difficult. But you're absolutely correct. See, we have a very high quality audience here. Okay, 33-year-old male. Alois. So we look at the distal tibia, we see the calcaneus. What's going on here? Here's proton density fat sat in T2. Notice that the cuboid also has a focus of involvement. What is this? Any thoughts? Oh no. So what's going on? Before we shoot for a diagnosis, let's first shoot for the actual finding. What is happening in the tibia and in the calcaneus? We have low signal on what? Something infiltrating. Okay. Now, if we look at what could be infiltrating, and we see this classic rim, if you look, it's dark signal, but we see the classic rims, right? So this is the bone infarcts, right? So these are bone infarcts, but multiple bone infarcts involving the ankle. What could be doing this? Here's 1 year previously, and we see, look what's happening. Now the tibia wasn't so involved, the calcaneus was, but look what's going on in the fat next to the calcaneus. What is this thing? See, this is 1 year prior. I'm showing it in reverse order. I'm actually showing it in the order that I got it. What's going on in this fat? Now, here's 2 years prior. What's this? What is this? This is pseudocyst, this is giant pancreatitis. Right, so this was 2 years previously. The patient had pancreatitis and then got bone infarcts peripherally and fat necrosis. So we think about bone infarcts, multiple bone infarcts, and even dactylitis in babies and in children following pancreatitis. But it's not something that we think about in adults, and yet we should, especially if you're getting bone infarct in funny area, and you look and you say, I don't understand why this person is getting bone infarcts. So this is pancreatitis, bone infarcts and fat necrosis. So for those who don't know what fat necrosis looks like, there's a lot of reasons for fat necrosis. This is fat necrosis. It's not, and not everything that looks like it's a little ball of fluid is a ganglion, especially if it has stuff floating in it. Okay, another 36-year-old male. Here we see the thigh. And what's going on? Vastus medialis. What's happening here? Okay, so there's a lot of increased signal we see on the stir. If we look on the T1, there's loss of the normal muscle character. On the T2, there's this thing. It looks like this hole, or this thing in the bone with a rim. And we can see that on the axial on the T2 also, surrounded by this edema or this change in the muscle character. Any thoughts?
Could it be a muscular infarct?
That is absolutely correct. This is a muscle infarct. And it's a muscle, the etiology of the muscle infarct, this patient was an unstable diabetic who had just been through a bout of ketoacidosis. So now, and he came with, after they got him out of the ketoacidosis, he had acute thigh pain. And we went over the people who were with him, and he had no trauma. Because when we looked at this, especially this circle, when you see something like this, then this is really characteristic for a subacute myositis ossificans. Subacute myositis ossificans very often has this little circular hole which people look and say, oh my God, it's some kind of a soft tissue sarcoma, and they go biopsy, which in the hands of the wrong pathologist can lead you down a bad area, because you see all kinds of primitive cells and mitotic figures and all kinds of crazy things inside a subacute myositis ossificans, and in the hands of a poor pathologist can be diagnosed as a sarcoma. But in this case, his story had no trauma at all. This person was, the American term for him is couch potato. He did nothing. And so we looked at them and looked at him, and the only thing he really had in his history was the recent ketoacidosis. Now, diabetic muscle infarcts is something that we know about, and we're probably missing a lot of them. So that was it. So those were my 7 cases. And so now I'll turn the table to somebody else. And thank you very much. You're an excellent audience.
Thank you very much. So thanks for the present, because Nogah wasn't supposed to be with us, so it's very nice that he's coming here. So the feeling nowadays that we'll have also residents coming and present, because when we first started this day, election day was supposed to be empty room, so we had the idea that we could ask our French residents to present some cases. So we'll alternate juniors and seniors presenting cases today. So I will ask for them to, some of them to come now, and then maybe Iris, and Gideon would present some cases too. So let's go for the French juniors. Supposed to be here. Okay. So just for the fun of it, if you can just say where you come from in France, so that you can see that there are people from all over the place in France, not only Paris people.
Good morning. I'm Asmi Koulakian. I'm a French resident in a radiology department in Tarsal Coalition in Paris.
Louder.
Please. This is a case I've seen in a hospital Louis Maurier in Colombia. I'm going to show you Mr. R, 39 years old. He came because he has a pain and swelling of the distal phalanx of certain fingers. It involves both hands. There is an involvement of the nails. This has appeared for 3 months to 2 years, and he has another type of lesion on the right nostril. This guy has no past medical history. He works in a shop, he does ER, and he was born in France. He's Congolese. This is the lesion of his right nostril. You can see something, it's red, there is no pain. The picture of his hands, you can see the involvement of his both hands. It's asymmetrical. So, we are the dermatologists, and we make biopsy of the right nostril, and X-rays and blood tests. This is the X-rays. What strikes you? What do you see?
What kind of granulomas? Yes, syphilis?
So,
leprosy?
So you can see the destruction of the distal part of the phalanx on the same fingers where we had the lesion, on the thumb, on the third finger, here on the index. There is no other bone lesion, we have no joint involvement. So, we are in front of acrosteolysis. It's a terminal tuft vein erosions. This can be primary or secondary. We don't really know how it can happen. Maybe it's a vascular etiology. It's not specific to any etiology. But now you need to get some information to the patient to try to get the etiology. What do you want to ask to the patient?
Where is he from?
Congo.
He's born in France, but he's Congolese. You want to know if he traveled in some special countries? He did not. What else do you need?
Does he have an armadillo for a patch? Does he use vinyl chloride?
He lives in the neighborhood of immigrants from Africa.
That's a good question, but he has no neighborhood.
Do any of his friends or family have the same thing?
No. No one in the family, no one in the neighborhood. It doesn't seem to be something contagious. So let's see. No past medical history in the family. He didn't travel in endemic countries. No professional use for toxic substance. There is no tissue loss in his fingers, as you could see. He never had joint swelling or sausage-like finger or toe. And he has no dyspnea, he doesn't cough. Now, you are the radiologist, and what X-rays elements can guide you to the etiology? What did you search? When you have acrostolysis, what do you need? Just X-ray?
I'd like to see it just X-ray.
Only on the X-ray.
Foot X-rays too.
You look at the bone, you look at the soft tissues.
What X-ray elements? Can you see calcifications of nerves?
That's it. That's an important element because this can guide you to scleroderma. So, first of all, you have two types of acrostolysis. First, the band-like, which can guide you. None of them are specific, but band-like can guide you to a toxic exposure, to idiopathic form. And when you have only the resorption of the duct, this can guide you to scleroderma, hyperparathyroidism. Those can be associated. The most important is to try to find if there is calcinosis of soft tissues, subperiosteal resorption, erosive arthritis, and soft tissue nodules. That's because we have different etiologies. This is not exhaustive, but I tried to find out the most important. Primary or secondary hyperthyroidism. You have the subperiosteal bone resorption. You can see here in the radial aspects of the middle phalanx. You can have psoriatic arthritis, but you have the joint involvement. This is not our case. You can have rheumatoid arthritis, but he didn't have joint involvement, never swelling of the joints. Scleroderma, but he has no calcification in the soft tissues. He has no Raynaud syndrome. We said he had no toxic exposure. You tried to ask if he traveled because of leprosy, but there is also no soft tissue loss. In this case, we didn't go in front of frostbite burns. No vascular occlusion. He didn't have past medical history. We can get sarcoidosis, and he had no clue for diabetes or cerebromelia. Just to say that in acrostolysis, this can be primary, and you have the rare hereditary or not hereditary form, Duchenne syndrome. But you have associated lesions, and we find it in children. Now, you have his blood test results and the biopsy results. In biology, there is no inflammation, normal calcemia, and this is the histology which guides to the diagnosis. We have lymphohistiocytoid infiltration with no caseous necrosis. So this guy has sarcoidosis. This is a rare form of sarcoidosis in the bone. Usually this is not what we find. So a few words about osteosarcoidosis. This is rare. This is rarely discovered without cutaneous lesions. When you have osseous lesions, patients usually have pulmonary lesions. It involves hands and foot bones, and usually it's the middle and distal phalanx. phalanges, rarely the distal. This can be uni or bilateral and asymmetrical. In 1/3 of